Okay, good morning, everyone. My name is Dr. Angel Petropanagos. I'm an ethicist in the Ethics Quality Improvement Lab at Osler and part of OEHI. I'm here today to introduce our keynote speaker. But first, I'd like to briefly do land acknowledgement to acknowledge that I'm here on the present day Brampton, which has been inhabited since time immemorial by the Anishinaabe, the Haudenosaunee, the Huron-Wendat, the Mississaugas, and more recently, the Mississaugas of the Credit First Nation. Importantly, today, Brampton remains home to many Indigenous peoples, some of which who work here and are patients in this community. I'm a second-generation settler on this land with Greek ancestry, and I'm really grateful for the continued privilege of being able to work and live in Peel. But as part of that, I have a commitment, and I'm striving to better understand the past and present contexts of anti-Indigenous racism and colonialism. And I'm professionally and personally committed to building open-hearted relationships with Indigenous partners, being a better ally, and taking actions towards supporting the goals of truth and reconciliation. So again, today I have the privilege of introducing our keynote speaker, Leah Mourinho Stephenson, who's strategic lead of All.Can Canada. So Leah is a systems thinker and consultant driven by her lived experience and specializing in complex multi-sectoral issues, which are what I love, and I'm so excited, with particular expertise in healthcare in Canada. So in her current role, she fosters co-design and collective impact to improve early, accurate, well-delivered cancer diagnoses for everyone across the country. And a little more about Leah. She is passionate about social change, and so am I, so this is going to be so great. Her experiences as a daughter and caregiver for her late mother motivates Leah. Her mother was a physician who overcame poverty, war, gender discrimination, and other systemic and personal obstacles, who struggled against melanoma and recurring endometrial cancer, all while remaining focused on ending the suffering of others. So Leah helps identify and establish effective approaches for individual, organizational, and collaborative action to help achieve needed outcomes for our diverse communities. And All.Can Canada is a national multi-stakeholder network for cancer care efficiency with the aim of improving the experiences of people with cancer. And I'm sure Leah will speak more to this through her talk. A key project of All.Can was the report, which we'll be hearing about today, to identify structural barriers in the Canadian healthcare system to more equitably improving cancer diagnoses. So I'd like to now welcome Leah to the podium to present her talk entitled Equitable Cancer Diagnoses for and with Structurally Underserved Communities, including First Nations, Metis, and Inuit communities. So thank you, Leah.
Thanks, Angel. I don't know if I can live up to the introduction. I don't know. Have to tone down the bio or something. And I'm so honored to be here. Thank you, everyone, for joining. Let me see if I can. There we go. Here we go. So I'm going to share, and I'm going to try and condense a little bit too. So I might speed through some parts of these of this presentation. But what I would like to share today is just a little bit about, briefly, what is All.Can Canada? Who are we? Although I think you just heard our mission, so that covers a lot of it. A brief summary of what we have learned to date. So our focus, as you heard, is really around earlier cancer diagnoses, but I think you'll find, as I'm presenting infographics and information about what we have learned to date, that what we have found applies more broadly than to cancer diagnoses. I think you'll probably think that in your own minds. At least it's certainly, I've worked in many other different health condition areas and not just focused on diagnosis across the care continuum. And certainly, I think a lot of this applies more broadly. So a summary, what we've learned to date, and then I'm going to go, so I'm not going to take you through methodology and the rest of it first. I'm just going to sort of jump to the end, to the good stuff, and then I'll get through a bit more of the methodology and how we got to that, to these findings, and then some very short calls to action. What can we potentially do to support each other? And if we have time, questions and answers. I will try to catch up time for the next presentation as well as much as possible. So who are we? I'll give you a bit more about the history later, but briefly, our current strategic plan, which is about to be refreshed and renewed for next year. But our vision fundamentally is that everyone in Canada can enter into a seamless healthcare system, and everyone we're not saying Canadians, you'll see, because we want to incorporate the fact that refugees are here and not everyone has citizenship, so that everybody who is a resident in Canada can enter into a seamless healthcare system, obtain a swift, accurate, and appropriately communicated cancer diagnosis, and achieve outcomes, including outcomes that matter to them, matter most to them. So our mission is that we're led by patient groups and by people with lived experiences of cancer. We're a national multi-stakeholder network for cancer care efficiency with a preliminary aim on optimizing people's entry into the cancer care system through swift, accurate, and appropriately delivered cancer diagnoses. And these are our strategic priorities, and they're based off of what we learned through the mixed methods research that I'll be sharing with you. So, obviously, when we're looking at the diagnostic side of the continuum in Canada, that means primary care, primary health care is an important player. And so, the ability for primary care to have the knowledge, to be accessible, and to have the types of supports they need to be able to facilitate differential diagnosis is an important strategic priority for us. The importance of seamless care and what are all of those different enablers and tactics and strategies that promote seamless care. Patient navigation is one of them. Teams are another. There's obviously more there than just navigation. This third one is a bit of a cheat. It's actually probably should be two priorities. They're squished together. One is supporting appropriate information. And here, this is really on the patient side, what they need to know at different points along the trajectory. And we certainly heard a lot about that and created some knowledge products about that, which I will briefly share. And then on the other side, the effective, this is on the provider side, fundamentally that interoperable health information, the fact that providers need to be able, for high quality care and safe care, they need the information available, and they shouldn't have to spend so much time searching for faxes on the phone, trying to get information from disparate systems that do not connect with each other. And also, of course, patients and caregivers would like to access their own information, so that ability from that side as well. The promotion and the need for psychosocial supports, and then having robust quality and performance frameworks that are helping us understand and learn and improve as to whether or not where things are at and whether they're getting better or not. And then really equity is cross-cutting through all of these different priorities, and we need the capacity, the enabling capacity to do the work. I'll skip through these parts. I mean, what this basically says is that what we're trying to do is build relationships with the people who have influence in these different areas, mobilize what we're learning, share what we're learning amongst them, and support the development and the uptake of any tools and practices that are really helping people who are undergoing a cancer diagnosis and the providers involved in that process. And over the long term, we really want to see the system improve, and so that everybody within it is able to have a much better experience and outcomes. This is how we work, at least for the time being. We'll see if this shifts a little bit. We are a network, and we are this design, for those of you who are geeky like me, into how do we work collectively across stakeholder types. This is based on a collective impact and a constellation network types of models. We are convened by a patient group called Save Your Skin Foundation. They focus on skin cancer. They act as the secretariat and the backbone support that receives all the funding and then funds people like myself and our tiny little team to really provide the support so that this network can function and flourish. Our steering committee are the strategic group, really kind of like a board of directors. And then we have 3 working groups that dive into sort of some of our more functional sides. The stakeholder folks, who do we need to be engaging with and in what order? It's a complex system, especially when you're looking nationally. The evidence base, are we working in evidence-based fashion? And the knowledge mobilization, how are we conveying what we're finding to people in such a way that they're motivated to do something about those findings? So here's, as I said, I'm going to jump to the infographics, to some of the most, I think, telling findings that we have learned to date. So, this is our recently revised, a still marked draft, but it will very soon be final by the end of this year. What we call the current state of cancer diagnosis in Canada. And it's based off of what these findings saturated the patient interviews we did as part of our mixed methods. That center part, what other people have called the spaghetti map. And then we had limitations to our initial study, as I'll explain. And so the additional barbed wire and barriers and harms that are represented on the outside of the spaghetti map come from that further work we did on roundtables just this January. And so I'm going to start with that inner spaghetti map. Hold on a second here. There's a lot in here. It's all available online, so you can zoom in and you can sort of dive into all of the details that are here. But there were all of these, as I mentioned, these were all saturated findings. So it didn't matter where they lived in the country, what type of cancer they were, what their socioeconomic status was, what their ethnic status was. This is how people experienced a cancer diagnosis. And we looked at cancer diagnosis from the point of symptoms, so not including screening. We wanted to understand from because I think it's still something like 65%, it depends where you look in the world, et cetera. But even when for cancers where there are screenings, you're still looking at the majority of cancer diagnoses coming from symptoms. So screening is important. I'm never, absolutely, we need to increase screening. However, we really need to be paying attention to how are we detecting cancer earlier from that point of symptom presentation. So we found that there were 3 phases to a cancer diagnosis. So from that point of, it may not even be suspicion, it could also be called symptoms, because you don't have a sore lower back and think, oh my God, I have cancer necessarily, right? Or have a headache or whatever the case may be. But that earlier phase is you've got some kind of symptom and you try to interact with the healthcare system. And so of course, that's going to be a primary care physician or a nurse practitioner or a walk-in clinic, or if you have none of those things and you have internet, maybe virtual care, but something along those lines, that's where your first touch points are going to be. And what people were experiencing was, again, because many symptoms often are undefined, but even for where there should be red flags, like someone who's been coughing for, 2 months or something like that, and maybe have some other symptoms going along there, that should be a red flag for possible lung cancer. People repeatedly experienced that their concerns were not validated, that they were told, okay, it's not this or it's not that, or it's no worry, here, take some Tylenol. There was a lot of misdiagnosis, a lot of prescriptions that were unnecessary, and et cetera. And so people would cycle around going, as things would recur, they would go back. If depending on what the concern was, they might go visit other types of allied health professionals or complementary therapists if they could afford these sorts of things, or if they were referred to them. And then as things progressed and got worse, they might and often would go to emergency rooms. And sometimes diagnosis, if all of this could gets happened within that emergency room, they might be able to skip through some of that mess and get all the way to the other end. But people are cycling through this first phase of suspicion and symptoms for months to years. And as things are getting worse, the distress is growing. So that we get into the next phase, which we called investigation, at that point of first referral. So when that family physician or that nurse practitioner, and maybe in some places you might, like pharmacists can do a little bit too, of saying, okay, wait a minute. maybe we need to rule out some possible lung cancer, for example. So then they get into the investigation phase. And in that investigation phase, I think the best word to characterize that in the current state, let's see if I can move my notes. Here we go. Was overwhelming. Time and again, people in our study use the word overwhelming to describe the multiple facilities, specialists, labs, hospitals, et cetera, that they needed to navigate on their own. And they usually were not, it wasn't one place. And a lot of questions. So you can see in here a lot of the different types of needs and concerns people had. So information, either not enough information or no information or too much information. Sometimes people, they didn't know what was going to happen next. Like generally speaking, when they were referred in, it wasn't like, okay, this is what the process is going to look like. First, we're going to do a blood test. And then depending on the results of that, then you might need a biopsy. There was never that kind of wayfinding at the outset. And so then you're in it. And not different labs and providers would do different things. So did you get any kind of preparation for what that test was going to be? Did anyone tell you how the results would be conveyed? Who would convey them? Lots of questions about, is my primary care provider, if they had one, still involved with this? Do they have the information? Who's quarterbacking all of this? Well, the answer always ends up being the patient and their families or caregivers. Self-advocacy is all throughout this spaghetti map, because if you're not self-advocating your way through this, your months or your weeks will turn into years, will turn into, right? Because you have to, you must advocate, or your family, your loved ones must advocate on your behalf. A lot of breakdown in communication, poor quality of communication. And so all of this is delay upon delay. Fortunately, the majority of people we spoke with, at a certain point, they reached a more specialized team. It might be sort of a hospital facility or a diagnostic assessment program, but they got somewhere where they felt like, okay, wait a minute, this is happening a little faster now. I feel a little bit more like people are seeing me and paying attention to what's going on here. And they got to that point of clinical diagnosis. Okay, you've got lung cancer or you've got breast cancer. But then you get into the additional and final loops of, okay, the staging and the therapeutic options, the additional testing that's needed there. So genetic testing, highly variable all over the place. Pathology as extremely variable. So I think there has been recent studies released by the Pathology Association, the quality work that they've done on a couple of different types of cancers looking, and the variation in times were from 1 week to 2 months for pathology results to come in. So of course, the clinical implications of that in terms of therapeutic options are just enormous. I think that here in Osler, from my understanding, you are so blessed and to have the wisdom and the strategic foresight to build what sounds like a world-class lab with some of the best pathology possibly in the country and maybe even globally. So your own Dr. Brandon Sheffield is doing a lot of that work in terms of the variability in both the content and the quality and the timing of pathology reports. That also is leading, a lot of fantastic work right here in Osler, and making things like genetic testing and really quick turnarounds around pathology, world-class. But it's so variable across this province and across the country. So then you are into your treatment options, right? So other people have called this the spaghetti map. That it's also been called snakes and ladders, because in our current system where we don't have interoperable health information and we have so much fragmentation, you can be in the investigation phase, a fax gets lost, and now you have to get back to the family physician to get re-referred back in again, right? So you can slide from one point of the maze or the map and back down to another one, and more time as you are trying to get through it. So then we look at there's mainly three categories, I would say, of barriers and harms within this maze or this messy map. For people who are structurally underserved, for people who face significant barriers, we just heard about refugees, and that is certainly one of the segments of one of our neighbors, one of our community members that face significant barriers. There are many others, and they're facing a number of different types of barriers that are not only slowing their entry into this process, but if and when they do enter into it, they often experience some harm and then they're out again, or they're certainly slowed down, because the fear and the distrust is there. So the three different types, determinants of health, right? So are you housing precarious or unhoused? Don't have an address, don't have an OHIP code, et cetera. Barriers to health literacy, but also, people who are elderly, people who may have less education, language barriers, digital inequities. And it's wonderful and it's important that we bring in digital solutions, but they aren't going to work for everybody. If you don't have the connectivity, if you are perhaps from a certain generation where you're not comfortable with the technology, if you don't have the means for the technology or for the internet or the electricity required for that technology, if you don't, so it can be both the actual devices themselves or the use, knowing how to use those devices, or the actual supporting infrastructure such as broadband internet. If you don't have the money, we know not everything is covered. We have a somewhat universal healthcare system. There's a lot that is not included in it. So it costs money. And then rural and remoteness. It's a structural determinant of health. So we did hear from people who were having to travel long distances to the city and undergo sometimes, really intensive biopsies of very difficult parts of their bodies. And then they're just discharged from that hospital far, far, far away from home. And they have to cover their own accommodations and kind of figure out all of those pieces. So that's assuming you could afford all of that and et cetera, et cetera, et cetera, right? So those are some of the determinants of health. Then the other categorical area really is around oppression, dismissal, or lack of recognition of people's different identities. And let's not forget intersectionality, right? People have many different identities that play out in their lives, but things like racism, and so as simple as stereotypes that we all carry in our minds about different groups in society, ageism, both being perceived as too young for cancer, but also, too old to be tested, for example. Ableism, and we particularly had heard from people who were neurodivergent, but ableism obviously can apply to physical ability as well as mental ability, but, sensory and communication needs, for example, of different neurodivergent patients. Homophobia, transphobia. These are some of the different types of sexism, you name it. These are the different types of factors that can make people fearful to enter into healthcare. And once they're there, they feel that misunderstood, harmed, and they might step away from the process or certainly not trust it a heck of a lot more. And it'll be a lot slower for them to keep advocating for themselves. But that's another piece. The structural expectation of self-advocacy is its own massive barrier. It requires agency to self-advocate. And so if you don't have that sense of agency for a whole variety of reasons, including perhaps you've lived a lot of your life feeling like you don't belong because people are telling you or making you feel that way, or because perhaps you're from an older generation, like my mother's generation, there isn't this comfort with saying, hey, push, 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 push. I have to advocate for myself. And then the cultural generational, and other factors. So generational factors, discomfort with asking questions of healthcare providers, that sense of hierarchy, right? So trauma, whether that be adverse childhood events, whether that be intergenerational trauma, whether that be, you've just come from a war-torn country and gone through an incredibly difficult journey and are now living precariously in a new country. And a lack of trauma-informed care on the other side, on the system side. Language barriers, differences in worldview, and cultural factors. Cultural stigma is major. I just came back from a patient summit and heard from a South Asian stage 4 cancer survivor and talking about the cultural stigma in her culture, in her family. The word cancer, her parents, her family supported her so closely through her trajectory. Most patients don't like journey, even because it's journeys we choose and they're usually pleasant. But the word cancer could never be spoken in the community. It has so many associations with it. And she sort of broke down. There's blame because of, senses of karma. There's all of that. So there's a lot around there. So can be a lot of cultural stigma around different types of health conditions, but including cancer. And so you'll see also there's some different, these are actual quotes that are embedded at different points within the map as well. I'll just also briefly explain what worldview is, because it may be a newer concept for some people. The simple definition is sort of ways of knowing and being. It's kind of like the fish in water. We're all fish in water, and we take how we conceive of reality for granted. It's just reality, but it's actually been learned, and that's the water that we're swimming in. So a more thorough definition and explanation, I took it from a peer-reviewed article called Worldviews by Alison J. Gray. And she said in that article, a worldview is a collection of attitudes, values, stories, and expectations about the world around us, which inform our every thought and action. Worldview is expressed in ethics, religion, philosophy, scientific beliefs, and so on. A worldview is how a culture works out in individual practice. When you encounter a situation and think, that's just wrong, your worldview is active at that point. We have a natural tendency to think that what we believe is normal, while another's views are backward and superstitious. Even though your views are a result of how you were brought up, you can only understand them as being rational, balanced, and true. And it's only when you're facing someone else who's got a different one where you're like, what? Wait a minute. This is not making sense anymore. That's when you know you're dealing with a worldview, different worldviews situation. It was a big part of our report coming out of our interviews with First Nations and Metis, people with lived experience and physicians. We did not hear from Inuit participants. They talked about the foundational importance of worldview. It came through as a really overarching theme because it ultimately informs everything, all the way down to personal conduct. And so they really made the connection, and it's in the report. I copy and pasted it here. I don't know if I'll read the whole piece to you, but it's really huge. I mean, fundamentally, I won't read it, I'll summarize it. But basically, how a culture conceives of reality then shapes how it conceives of, okay, what are the rights that, are to be enshrined? Then that shapes the laws that you create, that then shapes the institutions that you create and the policies of those institutions, right? Which then, and all of this is then affecting how people conduct themselves, right? So there's a connection. And so there are different worldviews operating amongst different community members, and we're operating in our own worldviews. And when these things come into conflict, they can create a lot of challenges, and a lot of distrust and a lot of misapprehension of each other. And when we can understand that they're happening and we can embrace that some of our patients and family members are coming from these different worldviews, we can try to make sure that we have more welcoming and environments and ways of working with them. So this is one of the quotes that came from our roundtables. Relationships are built over 100 cups of tea. It was a key theme across all structurally underserved communities, and especially First Nation, Inuit, and Métis communities. Relationships at all levels, at that level of care, the micro level, at the institutional level, at the meso level, and at the macro level, at the level of how the system is organizing itself and the different parts of the system are trying to create a system. Relationships are absolutely key. And what this is telling us is it takes a little bit of time, you know, and it takes that repeated interaction, right? That consistency of care to be able to build those relationships. So it was a key theme in how to better address inequities. So this is the desired future state of cancer diagnosis in Canada. I'll start with the center and make the way out. And again, it's sort of starting with at that level of the micro and a bit of the meso, and making our way out to the more macro levels of the system. So in an ideal world, if someone's experiencing some symptoms and they're able to very swiftly, ideally, actually in an ideal world, they already have an ongoing relationship with a primary care provider, with a primary care team, ideally. And in the context of equity, I mentioned community health centers. There's other groups like Indigenous primary healthcare organizations. There's family health teams that do great work in this area. But ideally, the primary healthcare, it's a team, and they're a team that know how to deliver culturally safe, trauma-informed, trans-informed, and they're delivering primary healthcare. So that broader set of programs and services that are helping with prevention and promotion, as well as diagnosis and all of the good things that people need at that base level of the healthcare system. Ideally, there's community governance, so there's that sense of co-design, and they know that what they're doing is really delivering what people need, and it's accessible to you as you know, as soon as you have a concern, and you ideally, you know, it's an ongoing relationship throughout your life, or at least for as long as you live in that place, and maybe you move. But the referral for testing is, if not immediate, at least that differential diagnosis process is very, you know, swift, and it's not this sort of, okay, you've got 10 minutes, dismissed, come back again a couple of months later because it's persisting. You know, there is a more thorough differential diagnosis so that there is a more swift referral. Diagnostic pathway is explained. That means there is a diagnostic pathway in the first place, right? So that needs to exist so that you can then say, okay, this is what's going to happen first, second, third, and fourth. There are so many community resources in the world. People, ideally at this point, they are proactively pointed to where what some of those resources are, even if it's just sending people to the Canadian Cancer Society's community resource locator. That is a great, very comprehensive online resource that people can search by their postal code, and they can see all sorts of different types of community and psychosocial and other types of resources that are available across the country. And psychosocial supports are ideally, they're part of the team. You know, there are teams out there that have social workers, et cetera. So there's a warm handoff. You don't even have to go outside of that team or that clinic to receive psychosocial supports. But where that doesn't exist, then there is a quick offering. And something that we're learning about there is, you know, the level of distress people are experiencing, because as soon as someone says, okay, we're going to investigate a possible whatever cancer, distress begins for most people and for their families. As soon as the C word drops, distress begins. And for some people that can be full-on anxiety and depression, but for many, there's at least some degree of distress. So what I've been hearing from people that do psychosocial oncology one-on-one is that when they're able to offer workshops and more group programming, that takes care of a lot of the needs for people, and that their wait list shortens because a smaller number of people actually need to come in for that one-on-one counseling. So group work, including virtually, can do a lot in the early stages as people are experiencing that distress of just maybe it's cancer. Then ideally we have the clear pathways and the protocols and the rapid referral mechanism so that when you're getting into investigation in a lot more swift and clear fashion. In an ideal world, that could happen in one place, like right here at Osler. That isn't always the case, and that's fine. But then minimally, a person needs a navigator that is assigned, and ideally that person is part of the team. The diagnostic assessment programs that were once, a strategy here in Ontario, and hopefully will return again, did have navigators and navigation built into how they were operating. Ideally, the information is provided to the patient and their family about before each step, right? So that they know what's going to come next. Each step is explained before it begins. Testing options are explained. Test results are explained. Questions are answered. People know who's going to be delivering it to them and about how long they might have to wait for that. Communication is compassionate. This came up throughout, right? All throughout. Just the power of compassion throughout the system is huge. That providers are able to communicate with each other. And when I share this with like nurses and other providers, that one always rises to the top because it's a huge issue. Psychosocial supports are integrated. And then again, once they're into that final, okay, they're receiving the clinical diagnosis now, this is a swift process, pathology, genetic testing, whatever else needs to happen to get that sort of pathological and therapeutic information required to get the treatment plan options on the table, that this is a swift process. Information is provided about the type of cancer, the treatment pathway. I mean, what happened for some people is because they were just at that point of clinical diagnosis, they were given information about stage 4 breast cancer. They ended up being like stage 2, and they're freaking out. And their comment was, I don't want to know about stage 4 because I don't want to be stage 4, right? So they need the right information. Again, compassionate communication and psychosocial support. Surrounding this at sort of more of the meso and macro levels, there's ongoing cultural safety training of all healthcare providers and system decision makers. People need to understand, it's not just at that level of care and how we're designing our institutions where we need to have that ability to understand and work with people's differences. It's also decision makers themselves. They need to understand these things so that they can make the right resource allocation and policy decisions, right? Ideally, we live in a world where there's flexible integrated funding and resources and infrastructure that address local realities. When you're getting into equity, sometimes it's the most hyper-local responses that are the most effective. And a lot of innovation often has to happen in order to be able to figure out what's really working, what's working to reach some of these very structurally underserved communities who do not actively come into care. You have to go out and build those trusting relationships with them. So that ability to really fund flexibly at that very local level and using local community and peer strengths, because often, especially when you're looking at equity and structurally underserved, people trust in other people like them, right? And so groups like community health centers during the pandemic developed positions like community health ambassadors, people within the community from faith-based organizations, from community centers, who were trusted members of the community who would go into apartment buildings and community centers and faith-based organizations and talk about, in the case of the pandemic, COVID and, and vaccines, the rest of it. But in the case of cancer, about cancer, about screening, about the importance of the relationship with the primary care provider, and if they're having any kind of symptoms of going in to talk with them. We need to be able to more rapidly integrate foreign trade healthcare providers. My mother was trained in the Philippines. She was a physician, a pediatrician and an allergist or immunologist. When she came, I don't know what changed, but she came to North America in the late 60s and started practicing in Canada in the late 60s, early 70s. Her and her colleagues that came, you know, she came from a generation of there were Filipino physicians practicing here, Vietnamese, you know, Korean, you name it. And so there was this whole wealth of foreign trained physicians and healthcare workers in Canada at that time, serving their communities in their language with those cultural expertise. And yeah, that trust in the system that you have when you see someone who looks like you, knows your language, understands your cultural realities. So what we lost along the way somewhere between the late 60s and today in being able to really rapidly integrate this expertise into our system. We are literally losing newcomers. It's more than 50% of people who are settling in Canada are now leaving. Right? We are not holding them here, and they're leaving because they are trained professionals. When they're coming through the stream that requires the skills and the expertise, they're coming as professionals. Then they're arriving here and realizing they can't actually practice their profession. They're not willing to stay. We're living in a global world now where people would rather, you know, it's like, hey, I'll go back to Dubai where I could practice as a physician or an engineer, or whatever the case may be, rather than stay here and, you know, be an Uber driver or whatever the case may be. So this is a big issue that absolutely needs expedited, and it will solve a lot of our issues with, we're not going to be able to train our way out of our shortages. And then also integrating First Nation, Inuit, and Métis healthcare providers. And when we're looking at that side of things, we're looking outside of, we also have to look at, and you'll see the themes come through later, outside of regulated healthcare provision. There's a lot, there's a dyad that you hear about all the time of Western medically trained people working with elders, traditional healers, ceremonial leaders, peer workers from First Nation, Inuit, and Métis communities. There are groups like Indigenous primary healthcare organizations where that's the model of care. It's bringing the culturally specific providers and approaches to care with the best of Western medical care and providing both of that to clients, and they can pick and choose as they need. And those providers are working together to be able to provide the best safe care possible. We need a system of information that is real time. It's interoperable. For patients, it's portable. They can bring it with them. We need institutional and systemic, so at the level of the healthcare system, the ability, we need to be collecting the socio-demographic identifiers so we can data disaggregate, so we can understand what are the different outcomes compared to, you know, sort of the general population, so to speak, or the general population that's being served. What are the different outcomes happening for different structurally underserved communities? Are there differences? Is there variability? And then when we do something to intervene with that, is it getting better? Right? So we need to be able to disaggregate our data. In a beautiful future, we, you know, PROMs and PREMs would be regularly used for care, and those kinds of findings would be aggregated and publicly available, so people have a sense of, hey, where are things going well, but also so that different providers can learn from each other. Oh, hey, it's going really well over in Osler. I want to learn what they're doing well with this particular population or this type of intervention. And at the level of the healthcare system, we're actively looking at the quintuple aim and how are we doing across those 5 different domains. And around all of that, at more of the macro and almost mythos level, you know, the determinants of health are a protective factor. I was at that recent summit that I just mentioned that I helped organize. I saw our housing stock, our affordable housing stock in Canada. We heard from Finland, who has implemented housing first and has basically eradicated street homelessness in their country. Much smaller country, fair enough. But they had a massive crisis in the 80s, and they basically decided to implement housing first in the 80s and built the housing stock to do that, and including deeply affordable as well as supportive housing. And today, they're at the point of basically having eradicated street homelessness. But when you look at the housing stock in Canada, we had more affordable housing than Finland did in the 70s and 80s. We had something like 22% of all of our housing stock in Canada was affordable or supportive housing. We are now at 2 to 3%. You see the sharp decline in the 90s. It stopped, right? We stopped building it. We stopped incentivizing it. Whatever happened, it stopped in the 90s. So those determinants of health are protective. We need them to be in place for people. This all promotes social capital and trust. Trust is a relationship one-on-one, but it's also how we feel about institutions and about systems as a whole. And trust is eroding quickly, and we all see what it's doing to our democratic systems, right? So doing all of this is going to promote not just individual trust, but that more broader social capital and social trust. We will actually be bringing social justice to life by centering margins. And if we can serve the most structurally underserved, we can serve everybody. Understanding that there are different worldviews out there, including Indigenous worldviews, and respecting that and really incorporating that into how we think about how we're designing and co-designing what we do. We have equity-informed learning health systems, and these are all very big concepts. That's why they're out in the mythos here. And throughout all of this, what enables all of this is co-design, and co-design with people with lived experience. So whether you're designing a new program or trying to improve what you are already doing, whether it's at the institutional level, trying to understand, strategic priorities, whether it's at the level of policy and the system itself, we need to be designing with the communities who are implicated in what we're trying to do. And particularly those who are structurally underserved. So this is basically our sort of what we've been up to. So we're understanding sort of what's happening now, where we need to move to. And what we've been doing is trying to understand, okay, what are some evaluated practices that are out there that seem to help get from point A to point B? Or what are some other types of knowledge products we need to be creating based on what we're learning that can help us get from point A to point B? These are our different strategic priorities here at the bottom. And I'll speak to the first piece in a second, but the promoting seamless care, like we've basically found a number of case studies, things like diagnostic assessment programs, I mentioned them to you, that help promote seamless care, pathways, nurse navigators, peer navigation. We found a few different areas around, for the support appropriate information, we created here's what to expect patient information framework that needs to be adapted so that people are, as much as possible, proactively anticipating what patients and caregivers need along the trajectory and making it proactively available to them in an accessible fashion. So we created that framework based on what we heard. And then there's another sort of a case study of things that we have found that's been evaluated to work. Psychosocial support, same deal. There's a case study there. We're continually creating new ones. And we also, from a workshop we did at the Psychosocial Oncology Association, what those professionals told us when we asked them, what are the opportunities to improve psychosocial support when someone's going through a cancer diagnosis? We turned that into an infographic so that people can get a sense of the ideas of what can Osler, for example, be doing better to better integrate psychosocial supports as early as possible in a trajectory. Where we have gaps are in the primary care side of things. That ability to support primary care in more rapid differential diagnosis and clear pathways in. So something that we're exploring are there's quite a few pathways being developed, and they're helping from that point of investigation through to diagnosis. We're not finding pathways that help from the point of symptom presentation. So we know of examples in Denmark and the UK, and now I've been learning also about New Zealand, of where they have developed pathways that start from the point of, for example, I've been coughing for more than 2 weeks, 3 weeks, 8 weeks, pick your threshold, and I've got some other clusters of symptoms associated with this. oh, that means if you have those, you should go check for TB right away. You should go check for lung cancer right away. Okay, you don't have any of those red flags. Okay, keep going down. But literally, they're flow charts. There's better versions of symptom pathways that I've now seen through a group called Global Health Pathways. They've developed 600 plus pathways. Some are hospital specific, the others are community specific, so primary care specific, and they're not flow charts. And they start from points of from symptoms as well as from you think it might already be a lung cancer. So you could search by condition or you could search by symptom on the community side. And it takes you through, it starts with the red flags and then it goes through in a lot more user-friendly fashion, all of the different questions one needs to ask, ways to manage, and then it builds the local referral pathways right in there. So if there's a certain form you need to use, certain hours that they're open, et cetera, et cetera, et cetera, it's all tailored and it's updatable overnight. So that if there's a change in the system, they decided they want to implement a new rapid referral mechanism for a certain type of diagnostic trajectory, they can put it in and it will be in all providers' system the next day. So there's no lag in uptake from. The same thing with they're basically taking all of the international clinical guidelines and building them into these pathways. So if there's a change in guideline, that will be reflected the next day. So it's real time update and very usable for people. But we don't have anything like this in Canada currently. So we're looking at seeing what can we be doing to try to help bring these types of approaches to Canada. And then on the last piece around supporting quality and performance frameworks, our work did start to identify some possible domains and metrics that could be assessed around quality. But there's also an easier, we need a partner to develop that into something that's usable and robust. And there's also work done by All.Can International, who I'll explain who they are in a second if I have time. Yeah, probably don't. That covers off some more commonly used metrics, such as I'm trying to remember, it's time to diagnosis. I guess I didn't have it in here. Yeah. Primary care interval. I forget. There's like 3 or 4 in there. You can Google All.Can efficiency metrics, and you'll see they found basically 8 metrics across the cancer care continuum that are internationally used, and about 4 of them are applicable to the diagnostic trajectory. So I'm going to speed through this, or perhaps I'm out of time.
I think what we'll do
Yeah.
is schedule a full workshop.
Yeah. Oh,
Yeah.
really?
Yeah,
Okay.
I think we're gonna-
No need to do that. Okay.
Angel has some questions. Do you
Hi.
want to-
Okay,
Angel,
cool.
a question over there.
Sure.
Yep.
Son,
Let me
thank
just-
you so much, Leah. That was really interesting, and I'm looking forward to diving into the report. And I see lots of opportunities for Osler to maybe collaborate and start some of this work. And so my question, what I'm wondering, oh, perfect, thank you. What I'm wondering is if you have any advice or insight on how to help an organization like us, Osler, move from the current state to the future state. So I think in the strategic plan, I saw lots of action items, so things we could do differently. But I'm curious if there's any different ways of thinking that would be helpful for us to work towards to sort of, jump that chasm from current to future state.
Yeah. So, I mean, definitely using the framework and doing a bit of an assessment of sort of where are our strengths, and I think it's really important to start with strengths. And I'm a big believer in asset mapping, right? So, what are our strengths? What are we doing well in some of these different areas? And where are we? Okay. And then also, okay, so what are some of our weaknesses? Where don't we have as much, where do we have some gaps? Where are things not going as well? Ideally, in that process, like this could be done as part of a strategic plan, but ideally there is co-design happening there too. So it isn't just the more users and diverse users of the services are part of the thinking, the more interesting insights you're going to get. And because none of us, we're all coming from our our perspectives, right? We're all coming from our daily jobs and our lives and et cetera. And that limits our ability to understand what else is out there. So by, learning from and hearing from people who have direct lived experience that is very different from ours and who, if you're also from a completely different sector. So if you're a healthcare administrator or a provider of different types, the people who are actually trying to use your services, understanding from them, okay, what are we doing well in a given, whatever area of the strategic plan you're looking at, right? And where is there room for improvement? What are you struggling with, right? So I think it's really important to make sure that there's a meaningful engagement and co-design in that process as well. But yeah, you're welcome to use any of our materials if you find it useful. Obviously, it's specific to diagnosis. There might be more out there around other sides of the other parts of the continuum. But as I mentioned, a lot of this does apply, I think, more broadly. And so feel free to take it and use it as a bit of a framework for yourselves. But really do use things like appreciative inquiry so that you are thinking through the strengths and the assets and not just in the deficits and, oh my God, and feeling overwhelmed. And do use co-design and patient partnership and caregiver partnership and make sure that there is as much diversity. And think about who aren't we seeing, right? So doing some of that needs assessment around who's in our community, who's coming through our doors, and what's the differences between those two? And what kind of different practices might we want to try to implement that would help us reach those folks that aren't making it to our doors currently?
Thank you. That was great. I just want to invite everybody to join me in thanking Leah. Thank you.